perhaps other people, it's the ones 55, 45, anything less than 55, we actually consider that as premature coronary artery disease. Now, women are protected by their hormones. I'm sure that's going to be talked about. But here, the lipoprotein A. Okay, so here is smoking, hypertension, and stress. Diabetes, obesity, cholesterols, and the risk factors are modifiable and non-modifiable. So this is a non-modifiable. You can't do anything about your age, sex, family history anymore. You just happen to be annoyed with your parents that you were born to people who had coronary artery disease, but there's nothing more you can do about that. Now, smoking, hypertension, certainly something you can actually control better. Smoking, absolutely the single biggest, most important beyond family history risk factor out there. Diabetes, another strong risk factor, so this needs to be controlled. All these are controllable risk factors. And that's why the non-controllable ones need to be separated out from the controllable ones. They are in your hands. Now, the worst part is this, and I think you need to understand it. I hope you're noting it all down. But imagine, घर जाके ये lecture आप दोगे, सवेरे से सबको बिठा के. Can you imagine that scene? Your husband sitting there, okay, आप सुनिए. Normal BP, it's a multiplier effect. So if there's a family history, and a person starts smoking, that's not double risk factors, that's multiplying risk factor. If there's a family history and diabetes and the smoking adds on, it's multiplication. So say this is a normal person, a smoking adds on 1.5 times, a high cholesterol and a smoker becomes 3 times. A high blood pressure, high cholesterol, smoker becomes 5 times. You add diabetes to it, it becomes 15 times. So diabetic starts smoking, that's a disaster 5 times already. And therefore, people who have risk factors already, which are non-modifiable, should not take up any modifiable risk factor at all. And if they've got it, they should just give it up to come down to some baseline. So that's very important. That's very important for your own selves and in the care of your families to understand this and therefore be able to expand that. Do you know that public, in fact, families can actually, the health of the families are only changed by ladies. It's because the whole family listens to the lady of the house. It doesn't listen to the man of the house. And that's why it is been proven. If you actually transfer it to families, to relatives, to friends, that's going to be far more importantly listened than if a male member is going to transfer that. So take that responsibility up. Now, just want to tell you one more aspect before we actually leave it open. Yeah, no, we could why are we worried about women and heart disease? The problem is that it's not just all this thing about deaths and outcomes and everything else. Actually, women are from Mars is actually true. No offense, but there is a whole books written on women and heart disease because ladies do not present in the same manner from the blockages. Common symptoms are not that of squeezing, discomfort, and walking. It does occur, but that's not the commonest. Commonest is acidity, gas, nausea, uncomfortable feeling, ghabrahat. I tell you, this word ghabrahat needs to go into the Oxford Dictionary because I've tried to actually fathom this ghabrahat out. And I can't. There's so many who come with ghabrahat. Maybe you could help me to fathom this out. Okay, but there is perhaps we go whole science behind ghabrahat. Now, but there's ghabrahat, and therefore, it's never picked up in time. So that's one aspect of it. Even heart attacks do not necessarily present with severe constrictive pain. It may just present with acidity, gas, and that's why women tend to dismiss it, saying ki yaar kuch nahi, kal dikha denge. Sometimes it just presents as a back pain, an abdominal pain, and you just put it off as acidity, some other pain. It's always as if it's not presenting in the same vicious manner as it should be in males to wake them up and say, gosh, this is an emergency happening to me. It's not happening in women. So it's even the diagnostic tests, by the way, have a greater incidence of false positivity. So the TMTs in women are more often negative. ECGs keep showing little changes, and I know that you perhaps have come across this situation, hopefully not to yourselves, but to other ladies who've come and says, "Ye doctor ne kaha tha ki ECG kharab aaya, but फिर test हुए तो सब ठीक आया." And that's because more ladies tend to have abnormal ECGs than males. The TMTs tend to be often false positive, which means that or false negative, both ways, high incidence. That means they're non-specific. TMTs में तो कुछ पता ही नहीं चलता कि क्या हो रहा है. 50% of the times when it's positive, it turns out that it's absolutely normal arteries in ladies. And on the other hand, when it's negative, it can have a coronary artery disease. And similarly, the response to treatment of angioplasty and surgery is also variable. They actually fare worse with surgeries because of the smaller arteries, and ladies are smaller built. So we need to keep all those things in mind. So I'm not going to go into this, or neither go into this, the crushing season we all talked about before. And I think now I'm going to just what are the, I think by I need to educate you a bit more, so enough to make you a cardiologist, at least of sorts for the home. So yeah, this is how angiograms are done. This is, we heard of the TMT, the exercise test, and the nuclear test, and the echo. By the way, there's often a fallacy in everybody's mind that echo, which is an ultrasound scan of the heart, often come to me, but डॉक्टर साहब एको तो ठीक आया था, आप कह रहे हो कि हार्ट प्रॉब्लम आ गई, आप कह रहे हो कॉरोनरी आर्टरी डिजीज आ गई, आप कह रहे हो हार्ट अटैक हो रहा है, और ये एको तो ठीक आया था. Echo only looks at the valves because it's looking inside the heart. It can't pick up those arteries of the heart. It only looks at the valves inside the heart. So we pick up valve problems like blockage of the valve, narrowing of the valve, disease of the valves, but we can't pick up the arteries. Only if a heart attack has already occurred and the heart is therefore damaged and is not effective, then we can see on the echo the efficiency of the heart and say, oh my God, the efficiency dropped down by 30%, so a heart attack has occurred. We see that area of the heart not moving. So echo is a test for the valves and only to tell us whether there's a damage to the heart. But the angiogram, which is the main test, is is done through this. You see, this is the heart sitting right here, and it pumps out blood to the rest of the circulation. So this is the aorta. It pumps blood to the brain, to the arms, and basically all the parts of all the any organ, the kidneys, the intestines. Then it goes down to the legs and all the way the blood flows, and then backwards through these veins, the gray ones here, and backwards into the heart. Now what we do is puncture this artery in the groin under local anesthesia and send catheters, which are little tubes, very fine tubes, up there across here into the heart, and inject dye into the arteries of the heart and study those arteries. And these are the small catheters that we insert. That takes 4 or 5 minutes to perform. It's under local anesthesia. It's safe. It's practically painless. And if done by a person like me, it can be quite entertaining as well. So here we are, and then we intubate these catheters into the coronary arteries, inject dye into the arteries of the heart, and this is the pictures we get under the X-ray. And we see these tubes as we inject dye into them, running down in various branches. We look at it in different angles, look for blockages, and you see here, actually what we pick up is this artery, which should have been, this is a nice tube here, this is a nice tube. We look at these nice tubes going down, and suddenly here, it's no more a nice tube. It narrows down into something and then becomes big, and that's the blockage we pick up. We say, oh my God, this is 90%, this needs treatment. And this is, again, these are how clean, nice tubes look like. Absolutely brilliant. This is supplying the right side of the heart, going to the left side of the heart, nice clean tubes branching out into the muscle. Okay, and then you have a situation like this. This functions, yeah. And you see this narrowing out there. If the lights go down, you will. And here it is, right out there. This tube is no more a tube. It's actually narrowed down. And that's all cholesterol deposited out there. Therefore, the lumen is just narrowed, and we're injecting dye and opacifying the lumen. So everything is narrowed down, and all we're seeing under radiography control is this narrowing out there, because everything else is just cholesterol deposits, and it's just but a narrowing. And then we have all these methods called, very briefly, about calling what is surgery, these things can be treated by just putting stents in. Okay, what's a bypass surgery? Now, bypass surgery and open heart surgery. Actually, bypass surgery is no more an open heart surgery because it's truly a closed heart surgery. Heart is never open. Heart is only opened for valves, because the valves are inside the heart. So you've got to cut the heart open. Oh, and of course, now we've devised even techniques to just do valve replacement through angiography-like methods also. But in this instance, what happens in bypass surgery? Now, bypass surgery has been a tremendous technique from the 60s, where here is an artery, here's a heart, and I showed you this, and this is the artery running. Blood has to flow into these tubes to come to the various branches and be supplied. And then there's a block which is developed inside this tube, and the blood is not being able to flow in here, and a vein is taken out from the leg, a vein. And this is, of course, science just thought that perhaps if some tube of the human body had to be used, then it could be used as a flyover across this blockage. And obviously, you can't have intestines coming out here. So it had to be a vein. And therefore, so here it is. One end of that tube is, the vein is taken out from the leg. One end is anastomosed out here. The other end is stitched here. And now the blood which wasn't being able to flow across this, just takes a different turn and goes across this flyover, and now gets, all the blood. Similarly, there's an artery graft. This is an artery which supplies the chest wall, and the blood which was to flow can't flow from this blockage downstream, and this area can't get a blood supply. So now there's an artery which is implanted, so the blood takes this turn, this turn, this turn, this turn, this turn, this turn, and comes down here. So that's bypassed. Okay. And what happens in angioplasty? Well, in angioplasty, what happens is this. Here's the blockage. Here's the artery. Here's the blockage. This is a metallic tube. A stent is something like this, a stainless steel metallic tube, almost like a spring. It's mounted on a balloon. This is placed across the blockage. It's blown up at 18 atmospheres sometimes, and these are like 2 and 3 millimeter in diameter. So these little 3 arteries are no more than 2 and 3, maximum 4 millimeters in diameter. So they're really small. We see them magnified because we're using these image intensifiers, and we have them on big screens looking at us, but they're little tiny things in the heart. And we're implanting these, and these are 2 and 3 millimeters in diameter, around 2 centimeters in length, go up to 4 centimeters in length, depending upon the length of the blockage. We blow it up to 18 atmospheres, which is practically 20 times the pressure in the car tire. And this spring expands, and when it's removed, this stays in the body, and then the inner lining of it grows over this inside, almost like you created a tunnel, put in the girders, and then have the cementing through it. Then you've got a nice, clean-looking tunnel now. That's what happens into the arteries of the heart. In fact, much of this technology came through really the simple civil engineering concepts. I'm actually a glorified plumber in a way. And this is what the stent is all about. So this is this stainless steel device. Actually, this just shows that it's mounted on a balloon, and the balloon, which is 3 millimeters in diameter, is blown up, and this is how that crimped metal cylinder then opens up into it. And you can see it's like a net. So the side branches, etc., the blood flows through the side branches. If this works, this is interesting. Oh yeah, this works. This actually is very clear dramatic representation. Here's the blockage in the artery. And remember, this is a cross-section of the artery. You can't see it like this. This is only representative. And here's firstly, the blockage is right there. A balloon is taken across. It opens up the blockage completely. And then this was a wire which was placed across it, over which this balloon. And here's the stent coming in. And this is a stainless steel crimped on this. Here the balloon is blown up. The stent opens up like a net. It's fairly rigid. Now, of course, if I compress it, I could not easily compress. It actually keeps the artery open, and that's it. Oh, yeah, this is the important safety information. It just tells you that despite you might be giving a lecture at home tomorrow, don't do this. This is not to be done at home. So with these words, I think we would end my session and be now more interactive at seeing what all questions do you have. I think we should have it now instead of later, because, yeah, that's right. I think we should have it now, done later.
Good morning, doctor. I'm Mandeep Shergill here, right here. I wanted to know, what does a pacemaker do?
Right. Okay. That's a very good question, and I think that was one I should have clarified. But I thought I thought I'd just leave some things to myself, because if you became cardiologist in the short time, then there's nothing left for me to answer. Okay. I want to show you this. Let's see. You see what what's happening here? This impulse is coming. You see, the heart to contract has to beat synchronously, and that's why it's a pump, and every pump has to have a rhythm in terms of its contraction. We know that a heart beats at, on an average, anything between 70 and 80 per minute, and that's because the impulses, just like a house has a water supply and an electrical supply, our cars have a fuel supply and the electrical and the battery. The heart has to have that. It has the blood supply, which is what the coronary artery disease is all about, the obstruction in the blood supply to the heart muscle. But there's the electrical supply there of the heart, which is making it beat at 80 per minute. And that is because from this area of the heart, God's fascinating. Think of this as the impulse generator. This is so amazing that it lasts us throughout our life, that there's an impulse generator there, which actually starts off electrical impulses from here, which spread across the atria first, then spread across the ventricle, so that the heart starts, it's almost like a stimulator. Heart beats in a synchronized manner, the atria contract and the ventricle contract. The atria contracts, the ventricle contract. The blood gets pushed out, pushed in, pushed out through the various chambers. That is happening, and if actually that electrical impulse starts slowing down, so think that the battery is depleting now, and that the rate starts coming down, and it starts coming down to 60 and 50 and 40 as a part of degenerative process or other disease process, and sometimes in heart attack, this conduction. So this could, say, have a battery failure, or say the electrical wires could actually get interrupted from a heart attack having damaged this area. Then the electrical impulses stop going, and a person goes into an extreme slow heart rate of 20 per minute, 30 per minute, which is not compatible with normal output. Patient can collapse, faint, become unconscious because the blood is not going to the brain. That's when we actually put the pacemaker in. The pacemaker is then an artificial impulse generator, which has wires going into the heart, which is put under the skin, and then again makes the heart beat for 60 at 80 per minute. And the pacemaker over the period of time have become very, very good. They sense the body motion, they increase the heart rate according to the body motion, they synchronize the heart in a way, they become small and small, almost like a size of a big rupee, and last for an average of 12 years and can be changed very easily. That's what pacemaker comes in.
Thank you so much.
Excuse me, wanted to may I?
Yes, good morning.
Sometimes doctors advise you to have a 640 slice CT angio
Right.
as merely as a diagnostic tool, even with just because you're over 55 and you may be having one risk factor like a family history. So is there any justification for that?
Oh, very good question.
Second is, one 640 CT slice angio is equal to exposure of how many X-ray of say lung chest X-ray?
Okay, that's a very relevant question. And actually, they say it's 640, but it's not 640. Beyond a particular point, the technology actually has changed. So it doesn't get to the same slices. It's just different way now that it's actually sliced. So it's thought to be that if it was in the same technology, it would get to that, but it is being equated to a technology. I hope you understand. I mean, it's almost like the engine changed into a fuel-injected engine. So you'd say this now engine is equivalent to, 5-liter engine of the past, but this 3.2 aspirated turbocharged engine is equivalent to the past 5-liter. So the technology changed into these slices beyond the 320. But what it is why should you actually have a CT? And remember, CT is radiation. And that is the whole issue about these CT scanners. Over this time, according to the technology, the radiation exposure has come down tremendously also from the same CT scanners, because that was a concern of the industry, of the scientific, the device industry, to actually decrease the radiation exposure. And I would at this moment say that it's equivalent to practically having 10 of those X-rays done. But the important point is, and that is why it's never repeated too frequently. So it has to be justified practically as even a screening test. The screening test has to be, there's a preliminary to that which is called a calcium score, which doesn't require a very high radiation exposure. And calcium score has been linked very clearly to the presence of coronary artery disease and a person's outcomes. So what everybody should be really doing is doing a calcium score in those high-risk people. When we talk about, at the 55, no, but when we talk about a very strong family history of coronary artery disease, then after a particular time, if the person has a second risk factor, say cholesterols, high cholesterols, then certainly beyond the age of 60, I would do a CT scan once on that lady. The reason for that is that our targets for cholesterol matter on, and CT picks up very early blockages. It picks up even 10% deposits, while other tests pick up blockages when they go to beyond 70%. Now, we need to understand that a person who's got a risk factor and perhaps a family history and a second risk factor is developing blockages enough for us to be able to lower it aggressively to those levels which we would think are important for that individual. And that may actually be that we need the LDL cholesterols to be less than 70. And to achieve those, I would actually do a CT once in a person with risk factors. And after that, I would not repeat it ever again for at least 5 to 7 years, 10 years, to be able to decide subsequently if I didn't pick up a disease or I picked up very early disease. A calcium score is, say, the first step in diagnosing it. It's, again, a CT-based methodology. But it doesn't use high radiation because it's just picking up calcium deposition in the coronary arteries. And calcium deposition has been linked to presence of significant disease. So calcium score of 400 or more is considered important enough to have disease process. And then you can do the step. And calcium score doesn't require contrast injection.
How does stress?
Oh, we are? They haven't got. You see, they went into the wrong profession. No, Dr. Tripachari didn't.
Doctor, how does stress
Doctor,
contribute to
what
CST?
about a stroke? What about a stroke? What about a stroke?
Of the stent. You see, Dr. Gurinder Bedi is getting impatient. Dr. Gurinder
Can
Bedi
we
is
have
going to
it
answer
over
that.
lunch? We can have it over lunch, the questions.
So I think Dr. Gurinder Bedi is going to answer what's the disadvantages of stent. Gurinder?
I'll take it.
Right.
Now it's on.
What is the difference between
Okay.
a stroke,
Okay,
and
now
a
it's-
heart attack?
A stroke is usually the brain. So when a clot goes to the brain, think of it as an attack of the brain as opposed to the heart. And therefore, the circulation to the brain is lost, and suddenly paralysis occurs, and that's a stroke.
Nothing to do with the heart.
Nothing to do with the heart.
Okay.
About the statin
But the
controversy.
same disease process, by the way, cholesterol deposits and a clot going,
About the statin controversy, which is
just a minute. We'll have to move forward.
right?
And Dr. Tripal Chaudhary is going to give it.
Always a pleasure. Thank you.
The red scarf is working.
The go red for heart disease in women.
Doctor, later educate us about cholesterol also.
Just when I was having a great time with you all, they stopped it.
Doctor said he'll entertain us. He's a very good singer. So that's how he entertains.
This is another aspect of Dr. Said. So we have to call him again, I think. Yes.
Yeah.
बात है उन्होंने दिल की बात करी, क्योंकि उसके बाद हमारी ज़रूरत ज़रूर पड़ती है. Like he said, a lot has changed in the last 50 years. The age of puberty has gone down and age for marriage has gone up. Girls are becoming more independent. They are staying away from home either for academics or work. And this is leading to the need of a companion, both for her emotional and physical needs. Here is where we must make sure that we teach them about safe sex, sexually transmitted diseases, and contraception. Lifestyle changes have not only affected the heart, but they have also affected our reproductive health. Women are putting careers ahead of marriage and childbearing. The stress is leading to smoking, more alcohol intake, and occasionally drugs. With age of childbearing going up, we must understand that there are inherent risks involved with pregnancy after 35. Incidence of genetic disorders increases, especially Down syndrome. Women at a later age may find it difficult to conceive and hence need reproductive techniques. At the other end of the spectrum, life expectancy has gone up from 50 to 80. Women are leading 1/3 of their life after menopause. Hence, women should take charge of their life and health so that they can enjoy a better quality of life. Who is a gynecologist? Gynecologist can be broken into two words, gyneco and logic. So gyneco means woman, logic is knowledge. So she's the one who equips you with knowledge about yourself and takes care for you for your lifetime. From your first gynae exam to delivering your babies and through menopause and beyond. Your daughter's first visit, when should it be? 13 to 15 years of age. Please don't be scared. This is not when she's going to have her first internal exam. It's just an opportunity for her to develop a relationship with someone such that she's comfortable sharing personal information in the future. Most young girls are too scared or too embarrassed to ask personal questions from their mothers. A gynecologist is her best source of accurate and confidential information. It's also a time to teach her about pregnancy prevention and sexually transmitted diseases. If she has any problems of painful periods or irregular periods, she can discuss that and receive treatment for it. We must understand that there are rules to this game. There must be complete honesty on the part of this young girl, secure in the knowledge that there will be complete confidentiality on the part of the obstetrician. We should all know that we should not be scared of asking embarrassing questions because there is nothing that a gynecologist has not heard earlier. Also, a time at her first visit is to take your HPV or cervical cancer vaccine. Also, check out that she's had her rubella, hepatitis, and chickenpox, besides other adult immunization. There's a lot of talk and curiosity about the HPV vaccine or the cervical cancer vaccine. The primary vaccination starts age 10 to 13. Then is the catch-up period till sexual activity, and sexually active women can take it till the age of 26. I have a lot of women coming in their 30s and 40s telling me her friend has taken it, her children's pediatrician wants her to take it. Well, there's no role for the HPV vaccine beyond 26. The slogan is protect the daughter and screen the mother. At this period, the young girl may like to discuss about the changes in her body, irregular periods, vaginal discharge, safe sex, contraception, STD, immunization, and then we go on to the period when she's going to get married. In our country, we do have girls who are going to have sexual exposure for the first time after they get married. It's a time to reinforce contraception. A woman should have a baby when she wants one, not because she finds that she's pregnant. Also, all forms of contraceptions, and I think it's very important for the mother